Welcome to the official GlobalRPh YouTube channel. Whether you're looking for medical insights, the latest healthcare trends, or just some fun educational content, there's definitely something here for you. Hemochromatosis is a disorder characterized by the progressive accumulation of iron in the body, which, if left untreated, can lead to serious and potentially irreversible organ damage. Despite its relatively high prevalence, especially among individuals of Northern European descent, the condition is frequently underdiagnosed or misdiagnosed in clinical settings. This video reviews the current understanding of iron overload, emphasizing the clinical implications, risk factors, and barriers to timely diagnosis. Drawing from recent research and clinical data, we highlight the need for increased awareness among healthcare providers, improved diagnostic strategies, and earlier screening interventions. Our findings underscore the importance of proactive identification and management of hemochromatosis to prevent long-term complications and improve patient outcomes. Iron is an essential element for human health, playing an important role in various bodily functions, including oxygen transport and cellular metabolism. However, when iron levels in the body become excessive, it can lead to a condition known as hemochromatosis. This disorder, characterized by the body's inability to properly regulate iron absorption, can result in iron accumulation in vital organs such as the liver, heart, and pancreas, potentially leading to serious health complications. Despite its potential for tremendous health impacts, hemochromatosis remains underdiagnosed in clinical practice. This video aims to explore the reasons behind this underdiagnosis, examine the current state of knowledge regarding iron overload, and discuss strategies for improving detection and management of hemochromatosis. Hemochromatosis is broadly categorized into two main forms based on its origin. First, there's primary, or hereditary, hemochromatosis. This genetic form results from mutations in genes involved in iron metabolism, most notably the HFE gene. The two most common mutations associated with the condition are C282Y and H63D. Individuals who inherit two copies of the C282Y mutation, also called homozygous, are at the highest risk of developing clinically significant iron overload. Then, there's secondary hemochromatosis. This form occurs due to external factors or underlying medical conditions that increase iron levels. It's often seen in individuals receiving chronic blood transfusions, such as those with thalassemia or sickle cell disease, patients with chronic liver disease, or certain anemias associated with ineffective erythropoiesis. Hereditary hemochromatosis is actually among the most common inherited disorders in populations of Northern European ancestry, with estimates suggesting a prevalence of about 1 in 200 to 1 in 300 individuals. However, not all individuals with the genetic mutation develop clinical disease, and that's a phenomenon known as incomplete penetrance. Now, some key risk factors include genetic mutations, particularly homozygosity for the HFE-282Y mutation. Family history also plays a role. First-degree relatives of affected individuals are at higher risk. Ethnicity is important too, since people of Northern European descent show the highest prevalence. Gender matters as well. Men are more likely to develop symptoms earlier, typically between the ages of 40 and 60, while women are often protected during their reproductive years due to regular iron loss through menstruation. And finally, age is a factor, since symptoms generally develop in midlife, becoming more apparent after menopause in women. Hemochromatosis, a condition characterized by systemic iron overload, often goes undetected in its early stages because its symptoms are subtle, nonspecific, and can mimic other more common conditions. This frequently leads to delayed diagnosis and, unfortunately, missed opportunities for early intervention. Patients with hemochromatosis may experience a range of generalized symptoms that are easily attributed to other conditions, such as sustained fatigue or reduced energy levels, joint pain, often in the hands or large joints, abdominal discomfort, particularly in the upper right quadrant, reduced libido or other signs of hormonal imbalance, and even heart-related symptoms such as palpitations or shortness of breath. These symptoms can develop gradually, which makes it challenging for both patients and providers to recognize a unifying diagnosis. If iron accumulation continues unchecked, it can cause progressive organ damage, leading to serious, sometimes irreversible, health issues. These include liver injury, such as fibrosis, cirrhosis, and an increased risk of hepatocellular carcinoma. Endocrine disturbances can also occur, such as type 2 diabetes mellitus. Cardiac complications are another concern, including congestive heart failure, arrhythmias, and cardiomyopathy. Degenerative joint disease and arthritis may develop, particularly in the hands, knees, and hips. There can also be hyperpigmentation of the skin, giving it a gray or bronze appearance. And let's not forget reproductive dysfunction, which can show up as impotence, amenorrhea, or infertility. Despite being one of the most common inherited metabolic disorders, hemochromatosis is frequently underdiagnosed. Several key factors contribute to this issue. First, the symptoms are often nonspecific and overlapping. The early clinical picture of hemochromatosis is usually indistinguishable from more prevalent conditions, like chronic fatigue syndrome, osteoarthritis, or even depression. Without high clinical suspicion, iron overload may not even be considered. Second, there's limited awareness among healthcare providers. Many clinicians may not fully appreciate the prevalence or potential severity of hemochromatosis, especially when dealing with common complaints. This can lead to missed opportunities for screening, particularly in patients with subtle signs. And third, inconsistent screening and diagnostic approaches play a role. The absence of standardized screening guidelines means testing practices vary widely across institutions and providers, which definitely contributes to delayed diagnosis or even misdiagnosis. Timely diagnosis hinges on the appropriate use of both biochemical and genetic assessments. A stepwise approach can help identify iron overload early and accurately. First, there are two blood tests that are considered the initial screening tools for iron overload: serum ferritin and transferrin saturation. Serum ferritin reflects total body iron stores. Elevated levels suggest iron accumulation, but they can also rise in inflammatory states. Transferrin saturation, or TS, measures the percentage of iron bound to transferrin. A TS value greater than 45% is often the first biochemical abnormality observed in hereditary hemochromatosis. Combined interpretation of both tests improves diagnostic accuracy. Genetic testing for HFE mutations plays a vital role in diagnosing hereditary hemochromatosis. Identification of mutations in the HFE gene, most commonly C282Y and H63D, confirms hereditary hemochromatosis in many cases. Homozygosity for the C282Y mutation is most strongly associated with clinical disease. Genetic testing is especially useful for confirming diagnosis in individuals with abnormal iron studies, screening family members of affected individuals, and clarifying uncertain cases with borderline biochemical findings. In selected cases, particularly when liver function tests are abnormal or ferritin is markedly elevated, liver biopsy may be indicated to assess the extent of iron deposition and fibrosis. Non-invasive imaging, such as MRI-T2, can also estimate hepatic iron concentration and assess cardiac iron overload. Effectively addressing the underdiagnosis of hemochromatosis requires a coordinated, multi-level approach across the healthcare system. First, enhancing professional awareness is key. Continuous medical education initiatives should emphasize the prevalence, risk factors, and early signs of hemochromatosis. Improved awareness can increase the likelihood of appropriate screening and early detection. Second, The implementation of standardized screening protocols is critically important. Developing clear, evidence-based screening guidelines, especially for high-risk populations, such as individuals of Northern European descent or those with a family history, can help ensure that patients are tested consistently and accurately. Incorporating genetic testing, particularly HFE genotyping, into routine primary care evaluations is highly beneficial, especially for individuals presenting with unexplained elevations in liver enzymes, joint symptoms, or persistent fatigue. Early identification not only facilitates timely intervention, but also enables cascade screening among family members. Equally important is patient education. Providing accessible, patient-oriented resources that clearly outline the signs, symptoms, and risks associated with iron overload can promote informed self-advocacy and engagement in care and prompt individuals to seek medical consultation. When patients are informed, they're simply more likely to pursue testing or actually follow through with referrals. Early diagnosis and timely intervention are essential to preventing the progressive and often irreversible complications associated with hemochromatosis. If left untreated, excessive iron accumulation can lead to organ damage, including cirrhosis, diabetes, cardiomyopathy, and arthropathy, underscoring the public health significance of timely recognition and diagnosis of this condition. The mainstay of treatment for hemochromatosis is therapeutic phlebotomy. It's a straightforward and highly effective method that involves the regular removal of blood in order to reduce total body iron stores. This approach not only lowers serum ferritin and transferrin saturation levels, but also helps prevent iron from depositing in critical organs. The frequency of phlebotomy is tailored to each person's iron levels, with more intensive regimens used during the initial depletion phases and then followed by maintenance therapy. In select cases, especially for those who have contraindications to phlebotomy, such as anemia or inadequate venous access, iron chelation therapy may be considered either as an alternative or as an adjunct to standard treatment. Chelating agents, such as deferrazerox or deferoxamine, bind to excess iron and help the body excrete it, though these are typically reserved for non-hereditary or transfusion-related iron overload. While medical treatment addresses iron burden directly, lifestyle modifications play a vital supportive role. Individuals diagnosed with hemochromatosis are advised to avoid iron supplements and limit intake of iron-rich foods, such as red meat and fortified cereals. It's also important to moderate alcohol consumption, since alcohol exacerbates hepatic injury and increases iron absorption. Individuals are advised to avoid vitamin C supplementation because it can enhance dietary iron uptake. Consuming raw seafood should be approached with caution due to the risk of Vibrio vulnificus infections, which are more severe in iron-overloaded states. Hereditary hemochromatosis remains underrecognized and underdiagnosed, often due to its nonspecific symptoms and the slow progression of disease. Yet, it is one of the most treatable genetic disorders when identified early. Increasing clinical vigilance, particularly among primary care providers, is vital. Incorporating routine iron studies in patients with unexplained fatigue, arthropathy, elevated liver enzymes, or a family history of iron disorders can facilitate earlier diagnosis. Improving outcomes will require a multifaceted approach, including enhancing awareness and education across healthcare systems, expanding genetic screening in high-risk populations, refining diagnostic algorithms to reduce misclassification, and encouraging family testing in confirmed cases, given the hereditary nature of most forms. Ongoing research is needed to address key gaps in the current understanding and management of iron overload disorders. Promising areas of investigation include the development of highly sensitive and specific biomarkers to detect early iron dysregulation before end organ damage occurs, advanced genetic profiling to better understand variability in disease penetrance and progression among individuals with HFE mutations or other iron regulatory gene defects, and novel therapeutic strategies such as hepcidin agonists or modulators of iron transport proteins, which may offer alternatives to phlebotomy in the future. As we expand our knowledge of iron metabolism and improve diagnostic precision, the clinical approach to hemochromatosis will continue to evolve, paving the way for personalized preventative care that minimizes morbidity and preserves long-term health. Thanks for watching our GlobalRPh production. If you enjoyed the video and found it helpful, please smash that like button and subscribe to our brand new YouTube channel. We're bringing you a dynamic mix of content across a variety of topics, so there's always something fresh, engaging, and insightful just for you. Your support means the world to us. It helps us grow and keep delivering exciting, high-value content. Stay tuned, because the best is yet to come.